So it seems somewhat counterintuitive that a Roux-en-Y gastric bypass could be a treatment for Prader-Willi, and some years ago I would have argued that myself, but based on experience with some of our patients with craniopharyngioma, we reasoned that in fact it might be an okay thing to do. So here's the first of two patients I want to present to you. This is a young, well, not a young woman anymore, but she was born in 1973. Typical clinical features led to a diagnosis of Prader-Willi in 1975, subsequently confirmed to have a chromosome 15p microdeletion. So up until the age of 7, height and weight tracked along the 97th and 10th percentiles respectively. She lived at home in a supervised home environment with the cupboards and fridge locked. She had both obstructive and central sleep apnea and was treated with BiPAP, type 2 diabetes, chronic lower limb edema, and she lived in, at the time I met her, she lived in supportive accommodation and traveled independently to work each day. And she's reasonably high functioning. So this is how her weight tracked up to the point that I saw her, and then up to the point that the procedure was performed. So you can see the management at the Women and Children's Hospital, where CPAP was first instituted around the age of 20. She was in a trial of CCK that was spectacularly ineffective. She was treated with fluoxetine. Orlistat was introduced, which was surprisingly effective, probably the only time I've ever seen it that effective. Got an apronectomy at some point. There was a period where I was using sibutramine for all of the patients in our clinic with extremely good results, but then it was withdrawn from the market, and she ran very quickly into trouble with a whole range of issues, including swollen limbs, recurrent infections, and her diabetes. So we discussed with her the possibility of doing this procedure, which was done on the 22nd of May 2013, and this is the Roux-en-Y gastric bypass that was performed, done in a conventional manner with a 20 ml pouch and a 100 centimeter Roux loop. So nothing special, just the normal. Just by way of comparison, because I'm going to talk about this subsequently, is a laparoscopic mini gastric bypass. And that is a much quicker and easier procedure to do, and seems to be equally effective. Note, in both circumstances, the stomach is left in place, and this procedure is reversible if need be. So here's how things went. The operation went fine. It was an open procedure. She was discharged on day 5, and she continues on standard multivitamin replacement, and all of her biochemistry normalized pretty much. At 22 weeks, all medication other than metformin was discontinued. She does go on and off it a bit, to her detriment, I think, but so be it. And you can see in December 2012, her weight at 113 kilograms, and then in October 2013, wearing the same dress, which she did for me, you can see her at 88.2 kilograms, and then last month at 85.9 kilograms. That dress has long since disappeared. And she is extremely well. And you can see that her glycated hemoglobin is within the non-diabetic range and remains so, and all her other biochemistry remains normal. Here's the second case. This is a male born in 1983, again with the microdeletions on chromosome 15p. He has obstructive sleep apnea, has been treated with CPAP. Again, lives semi-independently in supported accommodation, although I use the word supported somewhat advisedly. He travels independently to work each day. Type 2 diabetes is increasingly difficult to control on 3 oral hypoglycemics, and there was a question about whether he would need to go on insulin, and problems with his weight and a whole range of issues, chronic lower limb edema, recurrent ulceration and infection, and he was running into big trouble. Again, reasonably high functioning and consented to have a Roux-en-Y gastric bypass. And I only have 6-month data in this young man, but here he is standing in my office showing me the pants he used to wear. And you could pretty much fit 2 of him into them. And you can see the remarkable response of his weight out at 6 months, and his glycated hemoglobin is now normalized. He only remains on metformin, and his testosterone and vitamins and all other medications have been discontinued. What is most striking about this, apart from the weight, of course, is the improvement in the leg swelling, their overall mobility, the improved duration and quality of their sleep. They're much more alert, much more awake. I only have an impression of better cognitive function, but no formal assessment. But what is clear is there's marked decrease in food seeking, food-related thoughts and food-related tantrums, an increased sense of satisfaction after eating, and an ability to terminate food intake so that for the first time in their lives they leave food on their plate. Notably also an overall improvement in mood, happiness and vitality. What about elsewhere in the world? So biliary pancreatic diversion has been tried and has been spectacularly unsuccessful other than in the very short term. Mini gastric bypass, which is the procedure I showed you, there's a report of 3 males with a mean age of 15.6, 2 hypertension, and both of those had severe obstructive sleep apnea. Their mean BMI was 51, very high fasting plasma acyl ghrelin. They all had uneventful surgery, discharged on day 5, resolution of their comorbidities, marked decrease in the fasting plasma acyl ghrelin, and they maintain their weight loss out at 2 years with no complications. So similar to what we see. And that was published in 2014. Another description of a patient with a Roux-en-Y gastric bypass. This is a male aged 30 with heart failure, severe respiratory difficulties and daytime sleepiness. He'd been seen with severe heart failure, at which time his weight was 146 3 months before, and was treated with diuretics and a weight loss medication called Mazindol. And his weight decreased to 108 kilograms by the time he underwent his procedure. This was done with a 50 ml pouch, which I personally think is too big, but nonetheless, and a 100 centimeter Roux loop. By 18 months post-op, the hypersomnia and respiratory difficulties had improved, but not completely normalized. His weight was 92.4 kilograms, with normal labs, including now a normalized HDL, which had increased from quite low, and a decreased and now normal LDL. And then finally, there have been some patients described where they've had laparoscopic sleeve gastrectomy. So this is the first, a female aged 8, which to me seems an extraordinarily young age to do this, who had impaired glucose tolerance, a preoperative weight of 112 kilograms, which is perhaps why they were desperate. And then post-operatively, at 9 months, the weight was 85.9 kilograms, and I don't have additional follow-up data on this. But here is a series from Hong Kong, published, 2 females, 1 male, some who had mini gastric bypass or sleeve gastrectomy. They were young, either adolescents or young adults. You can see the mean BMI in the range there. 2 had a sleeve gastrectomy, and 1 had a laparoscopic mini gastric bypass. And again, 2 years data reported here, which shows an extremely good outcome with 63.2% reduction in excess weight. And again, you can see the marked reduction in the fasting acyl ghrelin and no significant complications. So durable and effective and safe. So why does it work? And I thought I would spend a little bit of time talking about the science, because I think that, with some apologies about how technical this might get, because I think that it gives us some fascinating insights into the nature of this condition and the rationale for using this procedure as a treatment. So a lot of my work is now done on how the stomach, has been for some years, on how the stomach communicates with the brain. So within the stomach, there are mechanoreceptors and chemoreceptors that detect the amount and quality of the food we eat, and they tell the brain, by integrating the signals through the vagus nerve, what's going on in the stomach and in the proximal gut, and indeed in other parts of the periphery. So those integrated vagal afferent signals go to a part of the hindbrain called the dorsal vagal complex, or the DMV, because it's in the medulla, and signals go from there to the nucleus of the solitary tract, or the NTS, which is kind of like the hindbrain appetite center. So from that hindbrain appetite center, there are circuits that go to the other areas of the brain that are involved in appetite. So the hypothalamus, which is a fundamental sort of feeding and stop eating center, and then to reward centers, so the mesolimbic reward areas and higher brain regions. There are also projections, and actually to many places, but just for example, one set of projections goes to the visceral sensory thalamus, and that integrates gut signals that tell us we feel full, or and we should stop eating, and those pathways go to the neocortex, which is how those sort of feelings reach consciousness. So what happens in Prader-Willi syndrome, and how does it relate back to that? So it turns out that for one of the peptides in the brain to stimulate feeding or to stop feeding, it has to interact with a hormone called oxytocin. So a Gutti-related peptide, which is in the arcuate nucleus, triggers acute food intake, and it does that by inhibiting oxytocin, which sits in the parvocellular hypothalamus. Okay, so there's the arcuate nucleus, and that is the detector system for the periphery, if you like, receiving and integrating a whole lot of nutritional and hormonal signals. The agouti-related protein neurons then trigger food intake by inhibiting the oxytocin neurons. And the oxytocin neurons are reduced in Prader-Willi syndrome. Now, if you have a model where you knock these out, like SIM1 haploinsufficiency, then you get a similar phenotype to what you get in Prader-Willi syndrome, but in an otherwise structurally normal PVN. So you can recapitulate this abnormality in various ways. Now what's interesting is these oxytocic neurons project to the medulla and spinal cord, where they enhance the hindbrain responses to circulating satiety signals. And if you ablate those hindbrain neurons, then you get overeating. Now there's another set of genes which are from the MAGE or melatonin antigen gene family, and there's 3 of these. MAGED1, where if you make mice mutant for this gene, you get a severe reduction in hypothalamic oxytocin, but normal oxytocin precursors, so it can't mature. And they get a Prader-Willi-like syndrome condition. Nectin mutant mice, this is another one of these genes. Again, you get reduced hypothalamic oxytocin, but also another set of neurons that are responsible for the hypothalamo-pituitary gonadal axis, or what Tanya was talking about, testosterone and estrogen and fertility. And those neurons are abnormal, and you get a Prader-Willi syndrome-like condition. Now, the sort of relatively new kid on the block in terms of mechanism of action is MAGEL2. Because the human MAGEL2 gene and the mouse homologue are both paternally expressed and mapped to the Prader-Willi region. If you make mice that are mutant for this gene, they get a reduction in oxytocin in the PVN. That explains the feeding defect seen in the newborns. In other words, the lack of feeding, and you can rescue it by oxytocin in the mutant mice. So it appears that there's a specific window at which oxytocin will be effective, and for quite, I think, increasingly understood reasons. But also, MAGEL2 is expressed in the suprachiasmatic nucleus. This is the nucleus that regulates our circadian rhythms. So day-night cycles, sleep-wake cycles, and behavioral rhythmicity. So that if it's abnormal, you're going to get abnormalities of those cycles. MAGEL2 is also important in the production of growth hormone. And then finally, it's responsible for how leptin, which is the detector system for how much fat we have in the periphery signals to the neurons in the arcuate nucleus. So how does that work? Well, leptin will inhibit the agouti-related peptide neuron that I showed you before that is responsible for triggering acute food intake. At the same time, it will excite the POMC neurons, which switch off appetite. And these neurons are part of the stress response as well. They're very interesting. They have a whole lot of downstream pathways acting through melanocyte-stimulating hormone and melanocortin receptors. But note that they link to the SIM1 gene and oxytocin, and also to a protein called brain-derived neurotrophic factor. That's going to be important in a minute. Now, in order for the POMC neurons to respond to leptin, you need MAGEL2. And so you won't get, in the absence of MAGEL2, this normal pathway triggered in response to leptin, so you won't get the MSH, you won't get normal production or action of oxytocin if it was there, you won't get BDNF and activation of the pathways that BDNF regulates. And in fact, this explains many of the aspects of Prader-Willi syndrome, including the excess fat mass, the lower lean mass, the reduced follicular activity, and the infertility. So what about BDNF? So this is found in many parts of the brain, produced in an activity-dependent manner. It's involved in neuronal survival, neuronal plasticity, learning and memory, energy intake, and metabolism. So important stuff. And it functions downstream of that melanocortin signaling pathway, and it works on neurons in the hypothalamic PVN and VMH. But also works on neurons in the brainstem to regulate peripheral energy metabolism. So again, another circuit back to the brainstem. And in Prader-Willi syndrome, as you'd expect, there's reduced levels of BDNF compared to controls, at least in the plasma. Now, there's another circuit that is involved here, and that's the reward pathway that I mentioned to you before, where there is a circuit of dopaminergic neurons working through the D2 receptor that goes from the nucleus accumbens to the ventromedial hypothalamus, and those neurons work via BDNF in the ventromedial hypothalamus. Okay? And I'm going to talk how that all links up in just a second. Now, what about ghrelin? Because we've heard a bit about ghrelin today, and the active form of ghrelin called acylghrelin. So, in Prader-Willi syndrome, at least fasting ghrelin levels are substantially elevated, but ghrelin antagonists have no effect. And that's because the ghrelin receptor doesn't respond normally to ghrelin, but also there are very low levels of this receptor. So you've got a defective receptor and very little of this receptor. Also, ghrelin, at least insofar as it reaches the brainstem and possibly also the VTA, the ventral tegmental area, brainstem NTS is because of a neural circuit, so it's acting on neurons in the gut. VTA, it's reaching directly. It's activating the mesolimbic reward pathway between the VTA and the nucleus accumbens. Now, apologize that this is getting complex, but there's another gene cluster that can be abnormal in Prader-Willi syndrome, and that's called the SNORD116 gene cluster. Now, what this codes for, these small nucleolar RNAs, and what you can call them, if you like, they guide RNAs. So they guide a whole bunch of other processes involved in neural development or neural function or a variety of different processes. And a paternal deletion of these is a feature of Prader-Willi syndrome in some cases. And in mice, what you can see is that increasingly across the arcuate nucleus, PVN, and the ventromedial nucleus, as the mice mature, an increasing expression of the ghrelin receptor. In order for the dopamine agonists to switch off appetite, which is what they do, and create pleasure, but particularly for the appetite effect, you require a molecular interaction with the ghrelin receptor. So if you don't have the ghrelin receptor, then the dopamine can't work. And if you knock out the ghrelin receptor, then you're completely resistant to those appetite suppressant effects of dopamine via that receptor. And finally, this effect is mediated downstream by increasing BDNF, which is what I showed you before. That's that link between the nucleus accumbens and the VTA. So there's this very important pathway that involves ghrelin, the ghrelin receptor, the D2 receptor, and BDNF. And then you'll remember before the link to BDNF that also goes through leptin, POMC, oxytocin neurons, etc. Okay, so when you do a Roux-en-Y gastric bypass, this is not in Prader-Willi syndrome, what you see is a decrease in food cravings. So you see this for total score, 7-month, 14-month data, and it's particularly seen for fats and sweets and carbohydrates and fast foods. You don't see it for fruits and vegetables. So it does something to food preference and desire to eat for those foods that trigger reward areas. And in fact, you can show that there's a reduced food activation of the mesolimbic reward pathway. And that is mirrored by the desire to eat the high-calorie foods. And this is probably indicating a partial neural mediation of changes in caloric intake after a Roux-en-Y gastric bypass, likely via dopamine, and probably also involving ghrelin acting on the VTA. Here's some more recent data looking at various reward systems showing the difference between what happens with a Roux-en-Y gastric bypass and a laparoscopic adjustable band, which is what you do to people you don't like. So you can see that with the high-calorie foods, you get a marked reduction in the, well, if you're looking at all 5 areas, you see the reduced activation to the food. Also, you can see in the orbitofrontal cortex, but with differences to high calorie and low calorie. You see in the amygdala changes, less in the, well, you don't see much in the anterior insula. Here in the nucleus accumbens, there was a trend, but it wasn't significant, and you can see the differences in the caudate nucleus. Similarly, you see the change in food appeal, particularly with high-calorie foods. Not with all foods, but with high-calorie foods. And then a change in meal palatability that goes along with that. And the macronutrient composition is particularly a change for fat. I'm not going to dwell on the hormone changes other than to point out that in this particular study, the most notable ones were the post-meal GLP-1 and the PYY with much less of an effect on the ghrelin. But that's in comparison to another obese group rather than within Prader-Willi before and after surgery. Now, finally, some very recent data shows that high-fat diet-induced obesity alters the activity, sensitivity, and responsiveness of vagal afferent nerves in rodents, and that's substantially a lot of that comes out of our lab. But from others, they've shown afferent-induced activation of NTS neurons within the brainstem. And this is reversed by a Roux-en-Y gastric bypass, even when the animals remain on the same diet. Also, the Roux-en-Y gastric bypass, but not the vertical sleeve gastrectomy, triggers microglial activation in vagal structures of the NTS and DMV, remodeling vagal afferent organization in those areas. In other words, restoring the normal gut-brain communication between brain-feeding centers. So, finally, the Roux-en-Y gastric bypass, or the mini gastric bypass, is effective and safe for the management of Prader-Willi syndrome at least up to 2 years and provides profound improvements in quality of life. The effect is mediated by changes in gut hormones, so decreased ghrelin, increased GLP-1 and PYY, but probably substantially also changes to vagal afferent-mediated pathways between the stomach, the proximal gut, and the hindbrain that teleologically, if you like, balances off what is otherwise occurring from the abnormalities that are present in the hypothalamus with the neuropeptides that would normally signal satiety. What we don't know, of course, is the optimal timing, by which I mean is what age should this be done, the differential effects by phenotype, long-term outcomes beyond 2 years, 5 years, 10 years, etc., the precise mechanism by which this occurs, whether the effect can be enhanced with other pharmacotherapy, or whether you can, in fact, by understanding how the system works, use a pharmacological approach to recapitulate the surgical effect. Thank you very much.